practice. Without further delay, I would like to call upon Dr. Muralidhara Sharma sir, Professor Emeritus, SDMC Udupi, to take over the session. Welcome to you, sir.
Okay. Now I think you are able to see the screen as well as hear me.
Yes, sir.
Okay.
Yes, sir.
Now the point is about the investigations and the Ayurvedic approach to the investigations. Now, whatever I am presenting now is a presentation which was done to Ayurvedic club in England a few months back. Of course, there will be some more basic additions to that presentation. The basic issue is why the clinical test has to be done. What are the purpose of the clinical examination? Now, from Ayurvedic point of view, Charaka has described the purpose of the tests to be done. Now, when I say the test, whether it's a way investigation or the other way would be, the purpose of the test would be Ayusha Pramana Jnana Hetoho or Bala Dosha Pramana Jnana Hetoho. There are two aspects. One is about the status of the patient and whether the patient would be able to respond to the disease properly or not. And the other is about the disease proper as such. In addition to that, there is another utility, the prognosis. So status of the patient, status of the disease, and possible outcome. These are the main targets of the clinical examination. So once you are able to make out these three aspects, you will have a very clear picture of the disease, and then of course the planned treatment can be planned. Now to reach to this target, the methods of examination mentioned in Charaka Samhita are Prakriti, Vikriti, Sara, Samhanana, Pramana, Satnya, Sattva, Ahara Shakti, Vyayama Shakti, Vayas, Bala, Pramana. All these are the factors which we all know about it. Now, from Ayurvedic point of view, the clinical examination of a person starts the moment you hear about a disease condition. And it also starts with a intense involvement of the physician with the patient. And that's why Duta Nimitta Shakunam, the moment you hear about the patient somewhere or a history of the patient, though it may not be by a direct clinical examination, the physician has to start an intellectual activity of the possible disease. So when Duta Nimitta Shakuna is mentioned, it's about the intellectual involvement of the physician. It's not about only the superstition. That's all the important thing. And then in those days, the practice was something different, where a physician would go to the patient. It's not that the patient would come to the physician. It was not a hospital or centered approach. Instead, it was about a physician going to the patient and then treating the condition. That's the situation in those days of Charaka or Sushruta. The current medical practice is somewhat different. Now, in such a situation, once the physician starts to move towards the patient's home or patient's residence, he has to think about all possibilities, different possibilities, and look out for any of the possible interventions which could be gained on the way by looking at the plants and so on. So, Shakuna, Mangala, Anulomya are the possible supportive features which could be helpful to the patient during that situation. It could be like the environmental factors, whether it's the temperature around the area. It could be the specific plants which the physician would see, and hence which could be used in that possible disease condition. And Atram Abhipashyeta Sprushescha Pruchecha. Basically, the clinical examination would be of three categories: the Darshana, Sparshana, Prashna. You will have to examine the patient thoroughly, and you will have to palpate, and then of course the history has to be taken in detail. And you will have to examine the patient with all the possible sensory perceptions which you can see, like which you can make use of. It's all the sensory, starting from the smell to the touch. So all the sensations have to be utilized. It could be abnormal sounds which are produced, which could be abnormal visible signs which could be seen as such. Now that's one thing. Now in addition to that, there are certain specific clinical examination mentioned in the Samhitas. One is you may take the position of the patient. As the patient lies in some position, that itself could be one of the features of the diagnosis. The distributor's diagnosis, we use that. Aturascha yam desham abhikshnam parirakshati samvakshamanaha bahushah tatra shalyam nirdisheta. Just the other day, during the rounds, I have shown a patient of a fracture of neck of the femur and the position of the leg. So if you remember about that, by looking at the position of the leg, we could make the diagnosis of fracture of the neck of the femur. This is exactly what Sushruta has mentioned as a atrasya yam desham abhikshnam parirakshati. Due to the lesions at that area, the patient would be trying to adopt to a position where the patient will find more comfort, and looking at that position, we make the diagnosis. This is what we call as distributor's diagnosis, one of the branches of the clinical diagnosis which is used. And this is exactly one way of getting more information about the disease. Now, the other is, when I say the making use of the sensations, it's about looking at the variations of the color, like Shuklanam, Krishnatvam, Krishnanam, Shuklada, so on. So variations in the color, or it could be the variations in the consistency, palpation by palpation, when you see something which is soft or harder compared to the normal. Chalana, Machalatvam, mobility. So now these are all the clinical examination parameters which you adopt, which we now often consider as modern. It's nothing modern like, it's exactly the same. When you palpate or when you examine the color, you examine the movement, and then when you palpate, you feel the consistency, the mobility of the lesion, chalanam, achalatvam, achalanam, chalatvam, or the extent of the lesion, pruthunam, sanksiptatvam, sanksiptanam, pruthuta, something, a organ which is supposed to be small, and if it becomes enhanced, a hypertrophy or an atrophy, sanksiptanam, pruthuta, or dirghanam, husvatvam, husvanam, dirghata, variations in the size, or apasan dharminam, patan dharmitvam ja. Apasan dharma is a movement during the physiological movements, like movement during the respiration and or movement during the swallowing, so on. Those are all the features which you have to observe, and based upon the observation, you will have to make the diagnosis. Now, it's exactly the same what we see in the modern method. It's also the same when you go for the clinical examination. In the contemporary methods of clinical examination, all these variations are common. The variation comes in, the difference comes in only when you have the two aspects. One, the comparison to a normal, what we consider as a normal, and the other is about the technological tools. So these are the two additions which we have in the contemporary situation, and according to Sushruta, to decide whether it's a normal or not, a feature which you have observed in a patient, which is normal or not, whether it is normal or not, you have to compare it to yourself. The physician has to compare the features which you have observed in the patient and then say whether it is normal or not. Now, this is Atma Sadrisheshu, Vijnana Abhyupayeshu, Tat Sanihi Janiyat. Like, now, if you have to assess the temperature, you have to compare the temperature of the physician and then say whether it is normal or not. Now, this is a very interesting issue and a controversial issue. When you compare the temperature or any of the signs, physical parameters in a patient to yourself and decide whether it is normal or not, the first of the prior condition is you should be healthy. The physician should be healthy. If the physician himself is not healthy, then comparison to the patient would be producing lack of chaos. So one important basic necessity for a physician should be, he should be healthy. Now, that's the possible scope for the error. That's one of the criticism on that parameter. But the other way, there is some advantages of comparison to a person who is living in the same environment and comparison to a physician or a person who is living in the same area and with the similar life conditions has many advantages. The advantages would be, now to make out that advantages, you'll have to know how the normal or the abnormal values are considered in the contemporary system. So a comparison of the contemporary system of making like what's the normal and abnormal, and what's considered as a normal or abnormal in Ayurveda. In Ayurveda, normal or abnormal is considered by comparison to the parameters which you see in the physician. Whereas now, the normal or abnormal value, they are made out by collecting a data of a large number of population and then having a statistical graph. This has to be understood properly. Now, when I say a statistical graph, a parameter, like suppose you take the resting pulse rate. Now, if the resting pulse rate of a large number of people are recorded who are otherwise seeming to be healthy, now this is again important. And when in a healthy large number of population, you take the data and then draw a graph. Now, it's a statistical inference, a graph is drawn, and invariably in all such a large number of data, this is something which you have studied in statistics, I will not go much in detail, but when you see this graph, all the graph would be having a dumbbell shape. This is what we call as a standard curve also, or this kind of a median curve is seen. Now, once you have that statistical graph, you will have a median value which is assessed, and this median value is considered as a normal. Then, of course, you will have standard deviation, a scope of error. Now, interesting is that the scope of error is calculated based upon the statistical formula. I am not going to that statistical formula. I think you may be remembering about that statistical formula which you have studied. The important is there will be a large number of people who will have otherwise it will be normal, but their value will be beyond that range, and hence there is a possible error of making, or a possible opportunity of committing an error where a normal person could be considered as abnormal. To give an example, we consider pulse rate 72 as the normal. Now, if you consider the pulse rate of your own, probably hardly maybe once in or twice in a day, you may find your pulse rate being 72. Most of the times, either the pulse rate would be less than 72 or more than 72, and slightly there could be variation. So that cannot be considered as abnormal. So statistics is not a perfect method of making the diagnosis. This is one area. There is always a scope of error, and the scope of error is due to the statistical model where you will have the standard deviation, but still even with the standard deviation, there are the areas which are not really covered. You may be covering the majority, but not. That's one issue. Another important issue is, now in the biochemical investigations, what we do now in the contemporary system is, you do the test at one situation. It's suppose it's about the blood sugar level. Hope you have an idea of how that blood test is done in the laboratory. You collect the blood sample and then go through the process of a biochemical process, and then take the result of the sugar. So you may get the sugar level at one given time, at exactly at 6:45, you collect the blood sample, that blood sugar level is seen. But in physiology, none of these biochemical processes are such stage-wise processes. It's a continuous process. Maintenance of the sugar level is a continuous process. There is a response of the body. Once you consume the food, the glucose level slightly increases. Then the hemostatic mechanisms of the body, they try to maintain that glucose level in balance. When you are starved of food, when you do not take the food, there will be glycolysis, and hence there is an attempt by the body to maintain the blood glucose level at a normal range. This is what the physiology would say. But none of the investigations can assess that continuous parameter. Instead, you will have one stage. You will take the sample at 1 minute, at 6:45 or so on. Or to reduce the error of that observation, you may have 3 samples. When we say the glucose tolerance test, you will take the sample in the fasting level, then you will take the sample after half an hour, 1 hour, 2 hours or so on. Or you may just take 2 samples fasting and postprandial blood sugar level, and then have an imagination of the possible thing. Now, this imagination can be compared to what you could see in the earlier days of the real films. With the present days of digital film and digital vision, this doesn't hold good. But if you remember about the older days where you had the reel and then film there, the technology of what you see on the screen of you see the film is you will have multiple snaps, multiple images of the whole movement. And when these films are run at a speed of more than 16 stills per second, then you'll have an illusion, and that illusion makes you to see the scene. So when Amitabh Bachchan hits somebody, and if at all you look at the reel will not show the Amitabh Bachchan hitting as such. Instead, you will see a situation where a hand is slightly raised, and then after some number of, then the hand comes into contact with the villain's body, and then the hitting occurs. Now, what we do as a biochemical investigation is looking at that continuity in the form of the stills. It's not a real process. This is a very important thing we have to understand. Now, in the chemistry, Krebs cycle is often mentioned. Krebs cycle is a continuous process of glucose metabolism, and it's not like it occurs in form of jumps. We often identify around 16 or 26 steps in the biochemistry textbooks. If you read, you will have either 16 or 26 steps in between. Now, these steps which you study under the biochemistry, these are only such intermediary steps which are in between. But the process is not in form of a jumping. It's a continuous process. So none of the investigations, none of the biochemical investigations give you a total picture, but instead it will be given illusion of some multiple steps, and then you will have to build up these gaps. So when you have that stages in between one and the other, that gap has to be built up by your imagination, and hence that's not whatever you see in the biochemical investigation is not the real. It's an illusion, but of course it is close to the real. I am not degrading that biochemical investigation values. They have their own value, but at the same time you will have to have a clear idea of how it is done and what are the possible drawbacks. Now, and then another of the important issue is statistics. Now, all that what we consider as a normal and abnormal is based upon the statistics, and that statistics is a issue of illusion. Again, one of the possible area of the dangerous area. Like, to the example which I often quote is, the statistics says, suppose if a statistic says that one specific type of surgery has a success rate of only 1%, and then one patient goes to a surgeon, and then that surgeon has to operate the patient on with that specific procedure, and if the surgeon says that, see, you have a very high chance of survival because the success rate of the surgery is 1%, and I have operated upon 99 patients till now, and all the patients have died. You are the 100th patient, and hence statistically you have to survive. Now, a common sense point of view, how do you feel? Like a surgeon who has killed 99 patients and 100 patients going to him, whether the common sense would prevail or statistics would prevail. So that's the issue. Or the other way, the usual example of the statistics is the same. By statistics, you may have an average depth of the river, and depending upon that value, average depth of the river, if somebody starts walking, and if there is a deep, some deep hole in between, there is a possibility that you may be risking the life. So this is one of the examples for the statistics and possibilities of the statistics. This is one of the errors of the current method. Now, comparing the advantages and disadvantages of the statistics and the Ayurvedic parameter, Atma Sadrisha Bhava. That's the real values of, there is advantage in both as well as a disadvantage in both. We are now trying to see the disadvantage of the current system, the statistic model. But advantages of the statistical model is because it covers a large number of people, the data will be more realistic. But at the same time, there is another possible error, and the error of the statistics is, now, when we collect the data mainly from some geographical zones. It's quite interesting. Most of the data which we have, either it comes from America or Europe. The situations, environmental conditions, situations there are totally different from what it is in India or in other countries, some other countries. Again, to give more specific example, as per the textbooks, the normal hemoglobin level is 14 grams as such. So a person who has less than 14 grams of hemoglobin is considered as a diseased or anemic. But if you compare the incidence of hemoglobin in India, I think very few people would have 14 grams of hemoglobin. Most of the people would have less than that, 12 or less. And there too, again, quite interesting is people who live in an urban area, they have a relatively higher hemoglobin level, whereas people living in a rural area, they have relatively lower hemoglobin level. And then the statistics says that the people in rural area are anemic and urban area, they have a healthy blood. But the reality is totally different. The reality is the available oxygen in the environment and the this oxygen carrying capacity of the blood, they are totally dependent. Like in those areas where the oxygen concentration in the environment is lesser, like the cold countries like Europe, where the temperature goes to zero or so on, naturally the oxygen concentration in the environment is around 3%, 2% lesser than what we have in the tropical zone. In the tropical zone, oxygen concentration is nearly 20%, whereas the oxygen concentration in the cold zones is 8%. So if at all somebody has to survive in that cold zone, necessarily he has to have more hemoglobin, whereas a person who is living in a tropical zone, because he has plenty of oxygen, he doesn't need that much of a hemoglobin. And now unnecessarily you will be saying that people living in tropical zone are in general anemic, and people living in western countries are much more healthier. This has a perception which is seen, right? But this is not real. At the same time, that is also true, like a person who is living in a city, because he is in a polluted environment, naturally his blood requires more hemoglobin to carry the oxygen which is available in scanty. Whereas a person living in a rural environment and open environment where the oxygen concentration is better, he doesn't need more oxygen. So again, the whole policy of related to the health has a topsy-turvy approach where the people living in the rural area are unnecessarily loaded with the iron, whereas persons who are living in the urban area, they are considered as healthier. In reality, their health is poorer. They are exposed to the pollutants, and to live in that pollutant level, their hemoglobin level has raised, whereas the person is healthier. Now, this is the reality. These are the facts which are known, but unfortunately, the people are not accepting this reality and in real-time situations. At the same time, there is also another issue, like to make the standards. It also relates to the food habits. It also relates to the lifestyle factors. To give another frequent example, which we see in the clinical practice, is the serum uric acid. The serum uric acid level, as per the standards in which we see, is 7 milligram per 100 ml. And this standard is again drawn from the Western countries, where the non-vegetarian food is a normal or a routine phenomenon, and the low residue diet is the fashion there. Whereas in Indian situation, where more of the people are vegetarian, the amount of the uric acid which could be accumulated in the body has to be necessarily less. But unfortunately, we do not have a protocol of assessing the normal values for our situation in Indian situation. Whereas the data available from the Western country, of course, there is a very solid mechanism of collecting the data, and the averages are standardized based upon the Western countries. Whereas in Eastern countries, or so-called developing countries or non-developed countries, you do not have that kind of a model where the biological standards can be fixed based upon the population of that particular country, and we depend upon those Western country models. And again, it gives an impression that the people in the developing countries or developed countries are having a lesser health index compared to the Western. But reality is totally different. Persons who are in the developing or non-developed countries, they are more close to the nature, and hence they could be much more real healthier. And the whole approach to the health and the disease has become topsy-turvy, and there is a need to have a serious revision of these issues. Comparing to that, the self parameter or a parameter of comparing to another person living in the area, you can reduce many of those geographical errors, the errors which are related to the environmental factors. Like a person who is living in the same zone, and you compare the pulse rate or temperature of the patient in the same zone and same physiological situations, like when its temperature is in the environment is very cold, naturally the body temperature would be slightly raised by about 0.2 degrees to protect against that. Now, a person who is in the same environment and compares it to the temperature of another person, I think that would be a perfect model where these errors of these statistics can be reduced. That's the advantages of a parameter of a self-assessment. Now that the other concept of this, having a model of our own, Atma Sadusha Bhava, also has another value from the therapeutic point of view. It's not from the investigation point of view. From the therapeutic point of view also, Ayurvedic approach is the Atma Sadusha Bhava, where the dosage of the drug often is mentioned in the form of prakuncha, prasrita, or so on. Prakuncha is a fist which is a hand which is held in a closed manner, and the prasrita is an extended hand, and this is how the dosage are measured. And when you say prakuncha or prasrita, it's related to the size of the hand of that particular person. It's not a universal dose. So often there is a criticism that the Ayurvedic dosages are not standardized. Now that word standardization and the meaning of the standardization itself has to be reviewed in a different manner. Now, and we are still committing to an error. We standardize prakunja as 30 ml, prasrita as 40 ml, and so on. That's not really the correct view. The correct view of prakunja prasrita is the size of that particular person, patient whom you have to administer the basti. The dosage has to be calculated based upon the prakunja of that person, so that naturally the quantity of the drug would be suitable to that patient. Now, this kind of a concept is now being evolved in the Western system. In the Western medical system, it's not about the investigation, but about the therapeutics. The major problem in the Western system of medicine is the dosage fixation of any drug. The dosage fixation of the drug now is mentioned in terms of maybe milligram per kilogram or the milligram per surface area of the body. But this is now people now know that it has been understood that there is always a possibility of either a overuse of the drug or under prescription. The dosage can never be accurate because these standards are based upon the statistical model, which we have discussed now. And now they are trying to have a model where the administration of the drug will be based upon the therapeutic effect of the patient. So self-administration of the drug is the new development in the Western system, and in a few years to come, maybe by the time you start practicing, you will have a different method of dose calculation, and then you will remembering the statement which we have discussed. Anyway, that's slightly bit away from the point which we are going to discuss. Now, directly coming to the topic of clinical investigations. Now, investigations could be of different aspects, and those clinical investigations are directed at maybe enhancing the capacity of the indriyas. See, ultimately, it's not the computer or it's not the machine which makes the final opinion. The final opinion has to be made by a human being. The technological tools may help you to have a better perception. Now, to these scopes of the investigations, the investigation tools which we use in the contemporary system, they could be like enhancing the capacity to view directly, like an endoscope. When you use an endoscope, you can see more than what the naked eye could see. It can get into the stomach or get into the cavity and then see. So it's actually the darshana pariksha only. Or it could be the imaging studies like X-ray scan and so on, where you will have a different sorts of the vision. Or it could be a microscopic studies. Microscopic studies are where again you will see the minute objects which cannot be seen with the naked eye. Now all these three would be enhancing the capacity of the darshana pariksha, your vision. And unless there is a person who views that, who looks at that, these investigations would be meaningless. So you may have a machine, MRI machine, but the images of the MRI machine has to be viewed by a human being, and then the human being has to interpret the results. Then again, you have the darshana pariksha. So it's not that it's something unusual or something which is not mentioned in the Ayurvedic text. Then you have the biochemical studies. Biochemical studies are having the assessing the chemical reactions of two or more of the chemical reagents in a controlled manner. The Rasanendriya Pariksha and the Granendriya Pariksha also are really chemical tests. When you taste something, it's a chemical reaction which occurs in the tongue. Or when you smell also, a minute molecule of that substance, when it reacts with the nasal mucosa and then the sensory nerve endings are stimulated, you will have the real perception of the smell. So when you smell the smell of this waste, this the wastage, there's controlling or wastage processing unit there in the campus. It means some molecules of that wastage has entered into your nose and then entered into your body. So it's not that you are absolutely hygienic condition. So when you smell, some component would be entering into the body. Then comes the functional studies. Functional studies where a function of an organ is studied specifically, like the spirometer, which assesses the volume and movement of the air in the lungs and so on. So that's the electro ECG, where the electrical activity of the heart is studied, which is something unique and by which you will be really getting the real perception aspect. Something which is totally different from Ayurvedic perception is the microbiological studies. Microbiological studies where the organisms being responsible for the disease are considered as the priority, and studying of those organisms is one of the area, which is not a real issue from Ayurvedic point of view. Though Ayurveda describes about the microorganisms, the Krimi, Graha, Bhuta are discussed, but they are not really visualized by making use of any instrument, and the importance is given to the physiological changes which are produced due to the organism than really the organism. So otherwise, the scope of the investigations are almost similar to that of what we see in Ayurveda. Only thing is you have a better tool, a higher, large number of tools, technological tools, and you should remember about that fact, like these tools are not the ultimate, and there is no need to have a overall about the tools. Their real utility, their real value has to be understood. The investigations again should not be done unnecessarily. There should be a specific purpose. Whenever the investigation is done, there should be a specific purpose, and the purpose could be any of these. Either you screen for a disease. When you are suspecting a disease in a large number of population, you may screen for a disease, or screen to determine a risk for developing a disease. Like suppose like a person at the age of 50 has a higher risk of developing some cardiological issues. Then investigations to do that kind of investigation is justified. Then it's quite important. The investigations are to be done only to either rule in or rule out a diagnosis. When you have to have a probable clinical diagnosis. Only after having a probable clinical diagnosis, investigations have to be done. Any investigations done without having a probable diagnosis is primarily unethical. Or investigations also could be done to regulate the treatment, like any intervention, any treatment, whether any treatment can be given, whether the treatment, like when you are administering insulin, whether the insulin really needed in a patient or not, or maybe electrolyte imbalances, patient who comes with the hyponatremia, whether you have to confirm whether the patient has to be given a saline or not. And you'll also have to know like how much of the saline has to be given, or when saline has to be stopped. So start, adjust, or stop an intervention could be the other way. Then of course investigations also may be done to assess the efficacy of an intervention, like when you have given insulin, whether the sugar has come down or not. This also is one of the targets. Of course, assess the compliance with an intervention is whether really the patient is making use of that tool which you have suggested, drug which you have suggested or not, or even prognosis could be the target. Now, the standard is you will have to have a specific purpose for the investigation. A purposeless investigation, which we generally now use the word like health checkup, is not really ethical, but which has become a fashion. In the earlier days, when we were a student, like in the 80s, of course, the whole approach in the Western system also was different. There was a sort of medical audit in those days. Now it's not relevant. It has been changed. That whole approach has been changed. In the 80s, in the olden days, before the 80s rather, there was one component of the medical audit was to study the number of investigations recommended by a physician. If the number of investigations recommended by a physician had become negative by more than 50%, he would be barred. Like, so your probable clinical diagnosis method is wrong. You have to improve the clinical assessment. So important is finally it is the clinical assessment which is the main thing than the investigation. None of the investigations can replace the clinical assessment. That's the quite important thing, and this fact has to be kept in mind. And particularly those who come from Ayurvedic stream should maintain that identity of keeping that clinical assessment as the priority, investigations as only supportive, and with a specific target. Without having a specific target, the investigations are not to be done. Though this kind of an approach of a medical audit and then warning the person about the investigation, unnecessary investigation, has now become obsolete. Now there is a new idea or a new development of what we call as evidence-based medicine. And evidence-based medicine is not something ultimate. It also has lots of areas of criticism, and there is rather it's not only, it has to be criticized to a maximum extent. That whole idea, perception of that word evidence-based medicine has become wrong now. And of course, we will not go into that much of the controversy, but we should be aware of that. We should be sensitive about that. And we should not feel something awkward because we do not have the these tools of investigations. Ultimately, whether you have an extreme, very advanced tool of investigation or otherwise, ultimately the decision has to be made by a human being, and the clinical interpretation is quite important. If a clinical assessment of the patient is not done, there is always a possibility of some errors in the investigation and observation. This occurs quite frequently with the radiology imaging. Like you might have seen many of the radiologists giving an opinion based upon the images. A radiologist would be seeing only the images. He may not be seeing the patient. And you might have observed many times, I have just thrown out that findings which are given in the reports. We make a different diagnosis based upon the patient. Or if you have observed in the clinics like OPD, when a patient comes with all the investigations which are done earlier, I never see those investigations in the beginning. Only after having examined the patient, I go through the investigations which were done earlier, the diagnosis done by some other physicians earlier. These are seen only after having a clinical examination. This is all the quite important and sensitive issues. It's not, I am not that highlighting what I am doing, but these are important messages which you have. And that's the quite significant clinical approach, where only after having a clinical assessment of the patient, you go through the investigation, then only you will be able to make a actual diagnosis. If at all you look at the investigations in the beginning, reports of the investigations in the beginning, and then see an approach, there will be bias. By looking at the investigations, you will have a bias. Like this patient may have certain such and such possibility, and that bias keeps your intellectual activity suppressed, diverted, and you will not be able to make the exact picture. So that's about the real value of the investigation. So before we go into these investigations and their value, you will have to have this clear perception. Now, that's something like what we say as the introduction. Now, directly jumping into the investigations in the clinical practice. The first of the, and quite common, the most common investigation which we do is about the blood investigation. So we'll try to deal with that common blood investigations in the clinical practice and their utility. The process of doing this investigation is, I think we'll not discuss that. But at least certain aspects of the laboratory and the laboratory issues should be known to every clinician. One of the important would be the collecting the blood sample. See, in a hospital situation, collecting the blood sample, you may keep this responsibility, give this responsibility to a nursing staff or a laboratory technician. But when you start your own clinic, you may have a situation where you may have to collect the blood sample on your own. It may be possible. Though in the current situation where you have the laboratories everywhere and then you send the patient to the laboratory, but still this should be known. Now, whenever you collect the blood sample for any investigation, you should know the purpose of that investigation and how the blood sample has to be collected. The blood sample may have to be processed primarily under two categories. Either it could be the investigation of the serum or investigation of the plasma. Serum and plasma, I think you know about the difference. Serum is the fluid component which is separated after the coagulation. Blood is allowed to clot. So you will not add any anticoagulant to the blood, send the blood directly, and then the serum would be separated in the laboratory and then it will be processed. So any of the serological investigation, so you should know like for any of the investigation whether the serum is necessary or the plasma is necessary. For the serum, when you collect the blood sample, there would be no addition of anticoagulant. Now there are certain standards which are universally followed. The aliquots are the vacuoteners, they are called as vacuoteners, the collecting blood sample collecting tubes. To identify, to avoid the error, they have a specific color coding, and that color coding would be those where you will have to collect only the serum and there is no anticoagulant which is required. The cap of that tube would have red color. Now you go to the laboratory today and look at those different varieties of the tubes. The tubes which have a red color, they tube red color cap, they are used for collecting the serum where you will not add anticoagulant. So we collect the blood sample in that tube. That's a universal standard. That means it will result in a separation of the serum. When you use the investigation blood sample for assessment of biochemicals like glucose or such non-oxidizing substances, you'll be using sodium fluoride as the common anticoagulant, and that sodium fluoride containing tube would have a grayish color cap. For the hematological investigations where the cell structure has to be studied intact, or even to study the ESR, you will have to have EDTA as the anticoagulant, and that EDTA containing tube will have that violet color cap. So these are commonly seen in our laboratory also. Whereas if you have to study the coagulation studies, sodium citrate is used, and sodium citrate containing tube would be having a bluish color cap. Heparin is used for, again, as an anticoagulant, where the bone marrow studies are to be done, or you will have to ensure that the prothrombin level of the blood is maintained. In that condition, you will be using the tube which has a green color one. Citrate would be somewhat yellowish color, and in the EDTA again, you'll have some more variation, like the blood bank tests and so on. There, along with the EDTA, potassium is added. The color is slightly changed. Of course, these are may not be seen in our laboratory. Citrate or heparin or EDTA may not be seen in our laboratory. But in our laboratory, if you go to the laboratory, you'll see at least these 3 or 4 varieties of the vacuoteners. Now, it's quite important that the blood sample has to be collected in a standard parameter and in that standard tube to get the possible results. It's also true, like you also know when a venous blood has to be collected, when a capillary blood has to be collected, and these are certain basics which we will not deal with. I will not deal with that issue. We will directly go into the tests and observations and maybe how to interpret from the Ayurvedic point of view. So that's about the introduction to that. The next part is we will go into the investigations and their utility. And first of them would be the Raktana Manyavarnatvam, the color changes which are seen in the laboratory. I think we will continue in the next session. And as such, if there are any questions, I will try to answer the question today, and then we will conclude. Are there any questions? Right, okay. So we'll conclude and end up.
Thank you, sir.